Great. Hello and welcome to Conversations with Dr. Bachner. Once again, it's Howard Bachner, Editor-in-Chief of JAMA, and I am delighted to be joined by Michael Osterholm. Hi, Mike.
Hi there. Thank you for having me.
So Mike is the Regents Professor, McKnight Presidential Endowed Chair in Public Health, and the Director of the Center for Infectious Disease Research and Policy, all at the University of Minnesota. From 1918 through May 2019, he served as a science envoy for the health security on behalf of the U.S. Department of State. He's a member of the National Academy of Medicine. And in 2005, Mike Leavitt, the then Secretary of the Department of Health and Human Services, appointed Mike to the newly established National Science Advisory Board on Biosecurity. Mike, you've been at this a long time around public health, pandemics, epidemics.
Thank you. I have.
What strikes you about this one being different, Mike?
Well, I'm not sure it's different. I think what the challenge is that why weren't we better prepared? And what I mean by that is I just have an article, the lead article in this month's issue of Foreign Affairs, about pandemic preparedness. And the irony of it is that I wrote a piece in 2005 in a very similar vein about why we had to be prepared for the future pandemic that would occur and what we needed to do to get prepared. And it turns out that the editors decided to actually have me lift the first paragraph and the last paragraphs of the paper and put them as the first and last paragraphs
from
of
the
this
2005. Fast forward 15 years.
And they fit perfectly.
Yeah.
And so that gives you some sense of the challenge we've had is that I think as a whole, we as across the board, and it's not just a political party, it's not an administration, it's not any one discipline. Everyone lacked creative imagination to imagine that where we're at today could actually happen. And I think now we've blown by that and people realize it can happen, it does happen, and it's going to continue to happen.
We mentioned before we came on, I pulled the numbers. Hopefully they're pretty accurate from the New York Times. Just posted this afternoon, 35,000 new cases, 833 deaths. The number of new cases rivals the numbers in April, when it was much more concentrated and focused in New Jersey and New York. And just to remind people, during those weeks, there were about 2,000, 2,500 deaths a day. It's a big jump to 35,000 new cases, 833 deaths. What's the next couple weeks look like?
Well, I think we have to take a step back. And first of all, I have a disclosure to make that I think is very important, is that I know less about this virus than I did 6 weeks ago.
Okay.
And I think the more that we've learned, the more humble we need to be about what it means. Our group started tracking this in the end of December when it was still a smaller outbreak in Wuhan. And by the first week of January, it became very clear to me that this was not going to be another SARS or MERS diseases, both diseases which I've investigated both in the Arabian Peninsula and in South Korea. And what I meant by that is it was clear person-to-person transmission was occurring, and it was occurring likely before people were even clinically ill, unlike MERS or SARS, where it was the 5th or 6th day of infection before we saw transmission. On January 20th, we actually put out a statement saying that this was going to cause a pandemic and that we needed to be prepared for it, and that it meant that this would be a global impact. A week later, we put out a piece saying that the world probably would not recognize this was happening until the last week of February, first week of March, because it would take that long for the number of cases to build up in areas around the world to be detected. At that point, we were tracking completely on target with what was going on. In April, we put out a document from our center on scenarios, not models. I don't tend to be a big fan of models overall. They're all wrong. Occasionally, some give you information that you can use. But we put out scenarios and said, we're at 5 to 7% of the population, at that time it was closer to 5%, have been infected with this virus. For us to actually see it slow down, we would need to achieve a level of herd immunity, which we estimated at 60 to 70%. Today it may be slightly below that, but that we were going to have a long road to hoe to get there. And so we laid out 3 scenarios how that might get us from 5 to 7% to 60 or 70%. One was a coronavirus model that, again, we've not had a pandemic of coronavirus, so we didn't know. But what if it were just a slow burn, just continue to see cases occur and just continue to spread at some relatively even rate? What if it was a second model where it was more what I'd call hills and valleys, distributed across many areas at the same time, some coming on, some going off, etc.? And then there was a third one, which what if this is like pandemic influenza, where we've had at least 8 and likely 10 pandemics since 2000, or the last 250 years, for which if you look at those, 2 started in our North American winter, 3 in our spring, 2 in our summer, and 3 in the fall. And in every one of them, there was an initial wave that lasted for up to 2 to 3 months, and then a trough, a clear and apparent trough that had nothing to do with human behavior, no attempt to mitigate the pandemic. And then we see a big peak after 2 to 3 months. Well, this past week, we basically dismissed the pandemic influenza model. Mm-hmm. It's not happening.
Okay.
This is a ongoing, straightforward transmission. I liken it more to a forest fire. Wherever there's wood to burn, i.e. susceptible humans, is going to find them. And I think that what we're still trying to figure out is in the models that we suggested or the scenarios for coronavirus, what is it like? And I think it's more that hills and valleys, what we're seeing right now. I mean, we're watching in the United States almost a tale of 2 countries.
Right.
We have 27 states today that are seeing increasing cases, at least 10 of them major increases. And they're not just in the South, it's also the West and Northwest. Yet we're seeing in the Midwest and the Northeast a relatively low level where they're, instead of 27 cases, we're only seeing 11 states where cases are decreasing, but they are decreasing. This was all with the same openings, all largely roughly about the same time. The economies were basically recharged, and we don't understand why that's happening. What I would suggest is that just as 4 to 5 weeks ago, the South was, in a sense, almost feeling some confidence that they weren't seeing big increases as they reopened the economy. Look what happened overnight. Today we sit here with Houston, if it continues on track, may actually rival New York City for the actual number of cases that we're seeing there. And I think that, Howard, if there's one really important message is, if you wonder what's going to happen, just wait 2 weeks, and I'll tell you how it's going to be different than what I thought it was today. And I think that's the message we have to get across.
Can you, Mike, do you have a sense you can put the genie back in the bottle? And let me tell you what I mean by that. So I have read the reports from Houston. Actually, one of our associate editors is in Houston, and he has mentioned the last 5 days have been concerning, and now it's becoming frightening. Can you go back to social distancing and masking? Or once you're beginning to see the surge, is it too late?
Well, it's not too late to do something. I think New York and the New York City metropolitan area, the Lombardy region of Italy, Wuhan, have all demonstrated that you can, in fact, do something to affect the shape of the curve. But can you go back and, as you said, put the genie in the bottle? I don't think so. All you can do is basically limit the impact of what's happening. I think the question that follows from your thoughtful question is, so once you do bring down the number of cases, what do you need to do to sustain it? And I think that, for months, I would hear from many of my colleagues, well, if you only did it like they do in Korea, if you only did it like they do it in China, if you only, all these different locations. And look today, I mean, Germany, which was held out as a model, today has a major crisis on its hands with regard to transmission and meatpacking plants and what it's doing in the communities there. New Zealand, which has done a remarkable job, 2 islands of 5-point-some million people. Since declaring their island free of virus, they've now had at least 9 and likely 11 introductions of the virus that they've detected. And it just points out how vulnerable we are today. This virus is what I call a leaky bucket virus. If there's one small micro leak in it, it'll get out, and it's going to keep transmitting. The Chinese have proven that. If there was any location that did what I would call the almost draconian measures of limiting, it was China. And yet look at the struggles they're having today trying to contain this virus. Right.
I mean, quarantine 50 million people is beyond my imagination. So say you're like New York, Massachusetts finally come down, much lower amounts of disease. What do the mayors and governors in states that have initially been successful need to do going forward?
And I think this is the trillion-dollar question where humility has to be front and center. We don't know. We just don't know. I've heard over and over again this idea of test and trace.
Yeah.
I come from a career of public health. I was involved in starting the very first HIV contact notification program in the country in 1985. I've had a lot of experience with contact tracing. And I can tell you the combination of the problems with testing, which we've demonstrated over and over again, a lot of our testing is, I think, misguided. We need smart testing, a paper that we published several months ago about how to use the test more effectively, how to do contact tracing, another one that we've published, all basically indicating the challenges with this type of a virus where transmission occurs as early as it does relative to clinical onset. The fact that this is the one time when contact tracing, we don't have anything to offer anyone other than to stay in your place for 2 weeks and it don't go to work. I mean, even with HIV, we were able to offer people AZT. If you look at all these different models, and so I think we have some real challenges of what do we do to stop this transmission short of distancing. I think distancing is really the only focus we have, and it has proven to be successful.
Masking, Mike, does the masking and distancing, or certainly masking inside, but what's your sense of masking combined with distancing?
Well, one of the challenges we've had with masking is it's kind of like saying I have a semi-truck, a VW Beetle, and a trike, and they're all the same because they have tires. Masking is very different if you're talking about N95 respirators, if you're talking about a surgical mask, or you're talking about cloth face coverings. And we really have a need to really understand how effective each of those are and under what conditions they're effective. I'm actually chairing a group right now that we put together of 20 international experts on the area of industrial hygiene, respiratory protection, virus modeling, animal inoculation studies, etc., to see if what we can come up with in terms of what is the actual infectious dose of SARS-CoV-2. And what are the critical organs issues, meaning is it upper respiratory, is it lower respiratory, what are the particle sizes that play a key role? And we're then trying to use the modeling we can to understand what respiratory protection requires for it to really be effective. And I think that right now I surely support using cloth face coverings, but I think we really owe it to the public, we owe it to our colleagues to understand how well they work. I think the same is true relative to surgical masks and versus N95. So I think this is an area that we need much more clarification on. The second point I would make, however, we have just been doing a little work here where we've been following the news media and certain news shows that have lots of public footage. And we've been systematically looking at how people wear the respiratory protection, most notably the face cloth. Over 25% of all people that we can show on the screen have the cloth under their nose, meaning that, it's like fixing 3 of the 5 screen doors in your submarine. If we're going to use them, we got to use them correctly. And I think that's been a big challenge.
When people talk about the fall, so you have your pro sports, you have college, you have school. Now colleges have talked about finishing before Thanksgiving. Pro sports, football aside, have talked about finishing before the late fall. Is this because of the so-called second wave, or is this because of the concern about the combination of COVID-19 and influenza?
Well, first of all, let me just say that per my previous comments about what I think is going to happen relative to what's going to be like an influenza pandemic, I am not convinced there will be a second wave. I don't think there will be. I think that we're going to just see one onslaught where it shows up here, shows up there, it goes a little higher there, a little lower there. But in the end, it's just going to be like one river of virus flowing downstream. And I think that challenges us because a lot of people were counting on the summer season to get better prepared for the fall. And at this point, I don't think we can conclude that. I challenged people 2 months ago and they said, oh, we're going to have a summer hiatus, we'll see seasonality. This virus isn't that way at all. And in fact, if you look at the recent increases in cases, that have occurred among the 27 states I mentioned. 11 of those states are in the northern area or the northwest area where the temperatures have been very moderate. And there's not been air conditioning to take people inside, but at the same time, they've also been in very, very hot places. And we don't see the virus acting any differently in either one. So I think we have to be very careful about assuming that there'll be waves and or that the weather or climate is going to play a major role. But to get back to your point, as someone who's at an academic center, who is advising my president, somebody who has advised the organization of college presidents, somebody who's actually I'm a board regent member of Luther College in Iowa, which is struggling with the same issue. I can tell you the one question everybody wants to know is just tell me on September 19th at 4 o'clock, is it going to be a problem or not? And that's the last thing any of us can tell you. I tell them, just count on the fact that it's going to be there in your planning, but plan as if it's not going to be there, meaning that go forward right now. Let's hope that we don't see that activity, but if we do, be prepared quickly to pivot. And I think, for example, our own institution, I give great credit to our president at the University of Minnesota. We're going to approach this in blocks where instead of having full semesters, we'll try to get in whatever we can when we can.
Right.
We're going to come back on campus, but great efforts have been made to deal with the housing issue, our own contact tracing program on campus. And then we'll be done by Thanksgiving and not coming back again. And so I think higher ed is really trying to do a number of creative things that can be helpful to getting through the semester, even though COVID is obviously going to be with us.
We've talked with some other people about schools. 55 million children under the age of 18 go to school. They've largely been out of school almost everywhere in this country now for 3 or 4 months, and people are beginning to understand the tremendous consequences of having children out of school, both for the child as well as for the parents. What do you think the future looks like for, say, children under 10, children 10 to 20? Their attack rates are different. How they communicate disease is different. Trying to distance and wear a mask for 5 or 6 year olds just not happening.
Yeah.
So how do you see it around schools, Mike?
Well, this is a real challenge. As having been state epidemiologist and having had to deal with outbreaks of meningitis and a number of different diseases in schools, I understand that there is a major exception to our psychological approach to health when it comes to kids. When we're talking about adults and even young adults, it's okay to talk about numerators and denominators. We can say, okay, in this case, it's a chance of 1 in 1,000. It's a chance of 1 in 10,000. When you're talking about young children, it's all numerators. There's no denominators.
Yeah.
All it takes is one case of a severe disease in a school to cause such great disruption. And I understand as a parent and a grandparent why that's the situation. So one of the challenges we have is helping to support the schools in the sense that, we can't stay locked up forever. There's a price to pay for that relative to the lost education of our children. And so I think we have to navigate how do we best protect children. You've said it very well already on the transmission issues. Actually the frequency of severe disease and fatal cases is very, very low in this population, despite the well-described cases of Kawasaki-like illness, etc. So I think that the challenge is how do we help them move forward? A couple of things I think that's important here, though, that also I would add is normalizing schools is also part of normalizing regular medical care. And Howard, I have to tell you, my biggest concern is that kids are not going to die from the issue of COVID-19, but rather from measles and all the other diseases we're not vaccinating for right now. And we've got to get kids back into their medical homes. We've got to find a way to, with these clinics, to get caught up on childhood immunizations. I think this is going to be a huge challenge.
Yeah, the American Academy of Pediatrics has an interesting site. I went to it this morning. They count, at least in their database, 46 deaths for children in their database, and I think it's under 16 or 18. And they estimate that those number of deaths is less than the number of deaths from influenza over the last year, yearly for the last 5 years. But you are correct. I am a pediatrician. It is the numerator. It is definitely the numerator when it comes to children. I mean, we published the first large case series on the pediatric Kawasaki's-like syndrome from England about 2 weeks ago. 58 cases, very concerning. Children a little older than those who get Kawasaki's, 9 or 10 in this series versus 2 or 3 for Kawasaki's. But, of course, they had no denominator data, which from my standpoint, I'd like to know if you're trying to explain risk to parents. But nevertheless, it is a numerator issue with children. I interviewed Tony Fauci a few weeks ago, and then Paul Offit. They were optimistic about a vaccine. I was very encouraged having spoken to both of them. Paul subsequently written a viewpoint for us that will get published next week about the 5 vaccines that the U.S. government is backing. Given the individual's immunologic response, they think one of these vaccines is likely to be successful. I think Tony expressed some concerns about how long immunity would last. And both were concerned that even with trials of 30,000, you may not be able to know if it was effective. What's your sense about vaccines, Mike?
Well, I think all the points you just raised are valid. I think we're realizing, as the coronavirus experts have told us, that immunity with coronavirus is a very complicated issue. And I would suggest that just as HIV/AIDS caused a revolution in learning around immunology back in the 80s and 90s, I think coronavirus infections are going to do the same thing again in 2020 into the next few years. So I think it is a challenge to understand just what level of protection we have, how are we going to come up with a correlate of protection if we're trying to make vaccines in large volume, and then what is durable immunity? I think we still have real challenges with that because, again, one of the things we're counting on is, in a sense, trying to hit herd immunity through a combination of vaccine and hopefully fewer and fewer cases acquired immunity. But those are all up in the air. We just don't know. So I, like Tony, I agree that surely the earlier animal model studies suggest you can develop protection. It may not even be sterilizing immunity, but maybe that's not bad if, in fact, you can have a very limited illness, but actually have even a bigger immunologic hit out of it. But so we're all there. My big concern is that we're still not really ready to, I think, deliver this vaccine in a meaningful way. And what I mean by that is everyone is going to want it, because I promise you that if it comes any time in the next 10 to 12 months, we're still going to be in the soup on this virus. And 8 billion people around the world are going to want vaccine right now. We are in a challenged position as we've withdrawn from more of the world effort in vaccines by leaving the WHO. If we get an effective vaccine, well, good luck. But what if somebody else gets one first? It's not in our country. How will we deal with the distribution of vaccine by low, middle income countries with high income countries? I worry even about in this country. I have made the case repeatedly, and I did this with influenza, is that healthcare workers should be first in line. They have been at exceedingly high risk for acquiring this infection, and yet the pushback I hear over and over again is, well, you're just taking care of your own. And yet on a risk basis, I could make that case very well that they should get it. So I worry also about the delivery. A vaccine is only a vaccine. It's nothing until it's a vaccination. And I think that's where we're going to have to understand how we're going to deliver this. I worry about supply chains. There are people who want billions of dose vials right now that can be made. Can the glass companies make them? How are we going to deliver it? Right now, Operation Warp Speed is talking about the military delivering it. I can tell you from many of my colleagues in public health, that is not seen as a good idea. And so I think this is what we need to work on and work out. And I think the last thing, there were some lessons learned in the 2009 pandemic, where HHS, with good intention, kept promising influenza vaccine to the public long before it ever arrived. And when it didn't arrive on time because of challenges growing the virus, the people got very upset, concerned, and literally it threatened the credibility of HHS in 2009. I worry here that we don't overpromise when it might come, because I think that we will set ourselves up for failure. We just need a very objective, honest view. This is where we're at. This is what we know. This is what we don't know. And we're going to do everything we can to get it to you. But at the same time, we have to acknowledge there are going to be challenges.
Has the Swedish experiment failed, or is it too early to know?
Well, I guess you could call it an experiment. Some of us would say it was just some administrative choices that were a challenge. I think this is another example what I talked about earlier. If you want to see what's going to happen with something, don't tell me what the conclusion is today. Let me wait for 2 weeks, and then I'll come back and tell you what the new conclusion is. And we've seen that over and over again. I think what we need to do in this country right now is figure out how somewhere to get between the guardrails. One guardrail is we lock down society, much like they did in Wuhan, and we hold everybody tight until we get a vaccine. Well, we know that not only destroys the economy, but it destroys society as we know it. You can't do that. But on the other guardrail, we know that if we let cases go willy-nilly, we will overwhelm our healthcare systems. You're well aware of the data that's come out recently, even showing how the number of people with heart attacks and strokes did not show up at hospitals. Right. And what were the collateral damage issues there because of the overstressed healthcare systems? So we can't do that. So I have been saying for some time, we need to figure out how to thread the rope through the needle in the middle. How do we basically acknowledge we can't lock this down completely? So who does get infected? How do they get infected? Who do we left back out into the world of COVID risk? And I would just add, that's complicated. I actually had 3 different situations come up just in the past 2 days of individuals who it became known to me who went home for Father's Day to be with their older fathers, one case, one with an underlying health condition. Only in the next 72 hours after Father's Day were the 3 kids, 3 different families, diagnosed with COVID-19. Now, what did they take home to their fathers besides Father's Day love? And so one of the challenges we have is how do we actually bubble people that are at increased risk? And I don't think we've really gotten that one down yet. So to thread that rope, we have to acknowledge we're going to have some cases, but we have to acknowledge we can't sit somewhere on either guardrail. We got to find that middle ground.
Couple more questions. It's been a half hour, but I enjoy the conversation. We have friends and colleagues in Latin America. And, I read the newspaper. I'm going to be interviewing 2 colleagues from Brazil on Friday. Brazil's clearly struggled. What do your colleagues tell you about what's happening in South America?
Well, we actually do have some colleagues that are close to this. I co-chair a work group on Zika vaccine, the roadmap for that with vaccine diagnostics and therapeutics. And so we've actually had conversations with researchers there. And it like being in Lombardy region, Wuhan, in New York City, in Madrid, London, it has been a tremendous challenge. The difference being, of course, that they don't have the healthcare resources that we do in many other countries. So whether you look at Brazil, Peru, I could go through the laundry list. They've been hit hard. And just today, the World Health Organization put out a statement saying that the Americas were far from done, that the worst is yet to come. So I think this is going to have a tremendous impact on Latin America, South America as we know it. And, the thing that I find difficult is when we were in the soup, and the European countries were in the soup severely, it made national news in every country of the world. But when many of these countries in low and middle income country status has a major challenge, you hardly hear about it. And I think that's a challenge for all of us on a worldwide basis.
Yeah, it's interesting. We just got a viewpoint about that. What draws media attention? And clearly what's occurring in the U.S. I mean, the initial reports from China did, and then moved to Europe. And whether or not there'll be attention paid to low and middle income countries in Asia, Central America, South America, and then obviously in Africa is very, very unclear. A couple other questions. You had mentioned testing. Mm-hmm. So talk to my friends and my colleagues, and they often say, well, Howard, I'm feeling fine. Should I go get tested? Because it's now much more readily available. And I'm always thinking to myself, what is it that they want from the testing? They're doing okay. It's not like anyone they know has gotten sick and they want testing because they know someone's gotten sick. And then I would tell them to wait a few days anyway. Don't run out right away. You had mentioned earlier in this conversation appropriate testing. Who should get tested, Mike?
Right. Well, we actually put out what is basically called smart testing document. About it should be the right test for the right person at the right time with the right result for the right outcome. And I could give you many examples where that failed. A good example being just look no further than the White House when they were using a rapid detection test where we know that the number of false negatives is very high. And that if you're trying to bubble and protect the West Wing, why would you ever use a test that was like a leaky screen door?
Right.
And as your soul means, that's wrong testing. That's not smart testing. I think the challenge we have here today is just we really do have in part the wild, wild west right now in testing in this country. When CDC was unable to deliver on that first test, the reaction was, well, we got to get more tests out.
Right.
And so the FDA really allowed, beyond the emergency use authorization approach for both antigen PCR tests as well as antibody tests, a number of vendors to come online that basically, as was described by senior leadership in the FDA, is nothing more than junk, and yet they're out there. And so one of the challenges we have is how do you know which test is to use that will give you the results you're looking for? With the molecular diagnostic tests like PCR, we're not so worried about false positives, which can be a challenge if I told you were positive and you weren't.
Right, you want to come back. Right.
It's how do you false negatives, where in fact you might be infected and we don't want you transmitting, but if you come away with a test result that said you're negative, then you feel like I'm negative. So unless you're clinically ill, we think that this test really has a primary means there, as well as looking at healthcare workers who may even have a mild illness. We want to know if they're infected. The idea that, Willie Sutton once said when he asked why he robs banks, he said, that's where the money is. If today we want to know what's going on in our communities, our public health approach is everyone who is potentially clinically ill with COVID should be identified every day and tested that day. And that's how you're going to find hotspots. That's how you're going to find emerging problems. That's how you're going to know what the incidence is. This idea of doing widespread screening really carries very little public health utility. So that's a challenge. The second one is the antibody test.
Yeah,
that's even worse.
Right.
That one right now, with the given sensitivity and specificity of that test, for which we don't know if you have truly have a positive, what it means yet. But in a state like Minnesota or in Illinois, if you were to test the population, 1/2 or more of all the positives would be false positives. Now, what do I tell a healthcare worker? Okay, you're positive, but I don't know what it means. Besides the fact is 1 out of 2 times you're not really positive at all anyway. And so this idea of creating passport for immunity and all these kinds of things, I think, are really, really misplaced. And so I think that the antibody test as it stands today can be a very important tool for public health, doing serologic surveys of populations where basically the air is built into it. So if you do repeated samples in a community and you go from 5% to 12%, you know that really means you increase substantially because the rate of false positives holds true for all the way through. So I urge people not just to go out and get tested just for the heck of it. I've seen that situation happen where it's not meaningful in terms of when they get done with the test result, they say, so now what did I have? What happened here? So I think it's a huge issue.
Wearing a mask, social distancing, even vaccines have never been more political. The era seems to have changed for lots of different reasons. Some of it is leadership, some of it is social media. Do you worry when the initial data become available from the various vaccine trials that they'll become politicalized and that it will put the FDA under enormous pressure to potentially approve a vaccine with limited safety data and almost no effectiveness data? I mean, Paul brought that up. I was struck that Paul brought that up in our live stream. And then he and Zeke Emanuel wrote actually a piece concerned about what will happen and the amount of pressure that will be on the FDA. What's your sense of that, Mike?
No, I think Paul and Zeke have really hit on it in exactly the right way. I mean, people are concerned that there might be an October surprise somehow to influence political outcomes, and that how will we be able to trust those data? We already have a challenge in the anti-vaccine community where the term Operation Warp Speed was probably about the worst name we could have given that program, because it implied that somehow we would just speed right through and safety would not be a consideration. And I think that the FDA has been challenged on how well it's handled testing for this So you can argue maybe it would do the same thing with the vaccine issue. And if there was ever a time when we needed to have confidence and a really sound scientific statement for why these vaccines are important, why they work, why they're safe, it's now. So I think it's a very fair statement, and we need to make sure everyone understands that, we will be held accountable. And so whatever we put out there has to be our best science, and we can't sacrifice time and any other opportunity for good science.
I know you have children and grandchildren. I don't know their ages. One of my sons is 27. The other is 30. They want to protect me. And my niece and nephew want to protect my brother. Can 30, 40-year-olds who are healthy, can they go out and resume some of their life?
Every day you go to work, or before, I guess when we used to go to work, you'd get in your car or you'd take some form of mass transit. People like you and I fly a lot.
Yeah.
None of our lives are safe. They're safer. And we're always making choices about what we can and can't do or what we should do. And, we find that sometimes we have a different standard when it's our kids versus when it's us. But we all come together around what is safe or safer. And, I think, again, it's a function of the risk. What is the risk of you developing not only infection, but a severe disease, which I don't think we've done a very good job of helping the public understand that yet. But I know individuals who are younger than you and me, who otherwise were perfectly healthy, who died from COVID-19. The question is, what is that risk and what are we willing to assume? I'm willing to get in my car. I'm willing to do a number of things that some would say, well, that's kind of risky. To them, to me, it's just part of life. I fly to dangerous parts of the world for my work. I assume that risk. So I think the answer is, for me, I would assume that risk of being close in a way that is responsible. So I did see my grandchildren over Father's Day, but we maintained distance outside. And so I think we can take accommodations like that to do that. But I wouldn't be honest if I didn't tell you, and I don't think I'm alone, and I'm surely not asking you this question, but there's been more than one night I've gone to bed and put my head on the pillow and said, I wonder if tomorrow's my day. And I think you can't help but recognize that we're all human before we're anything professional.
Yeah, no, if I get like a runny nose or a small low-grade fever, I go, oops. What's happening today? And then I'm usually well 12 or 24 hours later. I mean, I have flown twice to see my family, with great care. It's just interesting how each individual relates to it. I mean, we really, in this case, the good news is, from an epidemiologic standpoint, we really know who the high risk individuals are. It's very true that the frail elderly, and you can pick an age range, 65 or 70, healthcare workers, sadly, you've already mentioned that, and then obviously people in nursing homes or associated with nursing homes really represents the high-risk group that we have to do everything possible to protect. So.
And I would also add, I think that there are some other ones that are really very interesting. When you look at the younger adults and look at where severe disease is, there are two underlying risk factors that seem to pop up over and over again. One is persons with obesity, and the second one is smoking. So if there was ever a time to advocate lifestyle changes to help protect yourself, it's now. As a way to reduce your risk. I think that's a huge issue. The other thing I think, and I know you all have been very concerned about this at the Journal, is also the racial disparities issue. And race ethnicity has surely been a very important determinant in this disease. And how we approach that, or how we look at that right now, is clearly a challenge, and one that we're going to have to do more and better in trying to deal with.
Yeah, we've had 4 or 5, 6 papers on it,
have.
And we have a number. We have a number more already that have been accepted, and more that are planned.
Thank you for that. Yes, it was helpful.
Part of our responsibility. Mike, it's been wonderful talking with you. There's a fan who wants me to say hello to you, and this happens periodically. Walter Stultians. I can't pronounce his last name. Wouter Stultians. Please tell Dr. Osterholm that his work is very much appreciated. He is one of the most reliable sources of information regarding COVID-19. Mike, the one thing that I'm humbled by is your consistency in saying how much we don't know and how much things seem to keep changing. That for me is a really important take-home message, and I think that's a bit different. I don't think anyone I've interviewed has been sure about what the future looks like. I think the one thing is you're quite sure it's unsure or unclear. There's just a lack of clarity, that we're still learning so much. Is that a reasonable take-home message from me, Mike?
I think it is, and I think one of the things, if nothing else, I've learned in my career is I'm a student first and a subject matter expert second. And I think sometimes we mix those up a bit. And I've seen far too many people of friends, colleagues who have been on TV or doing shows where with certainty they'll say X, Y, and Z. And I'm sitting there saying, I would love to know what your database is. And it's not to be challenging or critical. It's just, in the end, our effectiveness is in part judged by a public or by colleagues that trust what we have to say. And, I think it's very important to be able to say, I don't know. It's very important to say, but what I'm going to do to find out about that and why I think that's important. And so I do think that right now, I think we'd all do better in this business if we had a higher dose of humility on board in terms of understanding this virus is doing what it's doing, and we're learning a lot every day.
This is Howard Bachner, Editor-in-Chief of JAMA. It's really been a pleasure to be joined by Mike Osterholm. Mike is the Regents Professor, McKnight Presidential Endowed Chair in Public Health at the University of Minnesota, and a long-time public health infectious disease expert in epidemics and pandemics. Michael, thanks so much for joining me today.
Thanks. Thank you. Can I just make